Hi class, I'm Dr. Fife. I hope you all are doing well. I'm going to go over structure and function of the hematological system. Now let's look at the components of the hematological system. Blood consists of various cells that circulate in the cardiovascular system, and these are suspended in a solution of protein and inorganic materials known as plasma, which is about 92% water and 8% dissolved substances or solutes. Plasma makes up about 50 to 55% of blood volume. It's a complex aqueous liquid containing a variety of organic and inorganic elements. The concentration of elements varies depending on diet, metabolic demand, hormones, and vitamins. Serum, that's plasma that's been allowed to clot in the lab when we draw blood. Plasma proteins, about 7% of the total plasma weight. Albumin is about 60% of the total plasma protein. This is a carrier molecule for normal components of the blood, as well as drugs that have low solubility in water, free fatty acids, lipid-soluble hormones, thyroid hormones, and bile salts. The most essential role is regulation of the passage of water and solutes through the capillaries. Globulins, these are classified by their protein properties in an electric field, classified by their movement relative to albumin. Clotting factors, these promote coagulation and stop bleeding from the damaged blood vessels. Now the cellular components of blood, we have RBCs, also called erythrocytes, WBCs or leukocytes, and platelets or thrombocytes. Erythrocytes are the most abundant cells in the blood at about 42 to 48%. They're therefore and provide tissue oxygenation. Hemoglobin carries the gases, and the lifespan of the erythrocyte is about 100 to 120 days. It's a small disc with biconcave shape and the capacity to reversibly deform. Leukocytes, these defend the body against microorganisms that cause infection, and they remove debris such as dead or injured cells. We have granulocytes or agranulocytes. And with the granulocytes, these are considered phagocytes, neutrophils, basophils, and eosinophils. Agranulocytes are monocytes, macrophages, and lymphocytes. We have natural killer cells, which kill some tumor cells and some virus-infected cells. Now, platelets are not a true cell, but are regularly shaped cytoplasmic fragments that are essential for blood coagulation and control of bleeding. Lymphoid organs, the lymphoid system is closely integrated with the circulatory system. We have the primary lymphoid organ of the thymus and bone marrow. Secondary are the spleen, lymph nodes, tonsils, Peyer's patches of the small intestine. The spleen is the largest of the secondary lymphoid organs. There's mononuclear phagocytes that filter and cleanse the blood. Lymphocytes mount an immune response to bloodborne microorganisms, and the spleen acts as a blood reservoir. Lymph nodes are the vessels that collect interstitial fluid from the tissues and transport to areas for drainage. These provide filtration, and they're part of the hematologic and immune system. They're often the first encounter between antigen and lymphocytes. B lymphocyte proliferation in response to a great deal of antigen may result in lymph node enlargement. Okay, let's look at some alterations of these cells and hemostatic function. All right, so let's take a look first at anemia. This is the reduction in the total number of erythrocytes or decrease in quality or quantity of hemoglobin. Results from impaired erythrocyte production, blood loss, which can be acute or chronic, increased erythrocyte destruction, or a combination of these different factors. These are classified by their causes or changes that affect the size, shape, or hemoglobin content of the erythrocyte. Here I just have the classifications of microcytic, normocytic, and macrocytic. And we'll go into more of these different types here, but I thought this chart was good for showing the different types here. Macrocytic normochromic anemias. There's unusually large stem cells, megaloblasts, in the marrow that mature into erythrocytes that are unusually large in size, hence macrocytic, thickness, and volume. Hemoglobin content is normal, and that's why it's considered normochromic. Defective erythrocyte DNA synthesis, and it's commonly caused by deficiencies in vitamin B12 and folic acid. Defective erythrocytes die prematurely, so it decreases the number in circulation. Pernicious anemia, this is the most common type of megaloblastic anemia caused by a vitamin B12 deficiency. It's often with end stage of type A chronic atrophic gastritis. 60 years old is about the median age of diagnosis, more common in European descent and in females. Pathophysiology, there's an absence of intrinsic factor, and this is a transporter required for the absorption of B12. Clinical manifestations, these are usually developing slowly, and they're often severe once treatment is sought. Early symptoms are nonspecific and vague, such as a patient may have more infections than usual, mood swings, GI, cardiac, or kidney ailments. I have a chart, a picture here just showing some of the different clinical manifestations we may see. Hemoglobin 7 to 8 for this type of anemia. Classic anemia symptoms: weakness, fatigue, loss of appetite, paresthesias of the feet and the fingers, difficulty walking. Patient may have loss of appetite, weight loss, sore tongue that is smooth and beefy red, secondary to atrophic glossitis. The skin may become a lemon yellow, pallor, or icterus, and there may be hepatomegaly once that hemoglobin gets to this level of 7 to 8. Folate deficiency anemia. Folate or folic acid is essential vitamin for RNA and DNA synthesis within the maturing erythrocytes. So deficient production of thymine affects cells under rapid division, bone marrow cells undergoing erythropoiesis. Our folate dietary intake should be between 50 to 200 micrograms per day. This type of anemia is more common with chronic alcohol consumption or malnourishment. Alcohol interferes with folate metabolism in the liver and leads to depleted folate stores. Fad diets that are low in vegetables may also contribute due to the absence of plant sources of folate. Clinical manifestations: patient may be cachectic, malnourished, severe ichthyosis, which are scales and fissures on the lips and corner of the mouth, stomatitis, painful oral ulcerations, or burning mouth syndrome. Labs are going to show a low reticulocyte count and a high iron level. And this is treated with oral folate. Here's some different information here on different causes of folic acid deficiency. Microcytic hypochromic anemia or iron deficiency anemia. This is the most common type of anemia. Most common causes are pregnancy or chronic blood loss. Risk factors for this type of anemia include poverty, women of childbearing age, and children, females, chronic parasitic infection, and lead poisoning. Two etiologies: it could be either an inadequate dietary intake or there could be excessive blood loss. There's metabolic or functional iron deficiency. Clinical manifestations are going to begin gradually, and patients usually seek treatment when the hemoglobin is around 7 to 8. Early symptoms are nonspecific, but may include fatigue, weakness, shortness of breath, pale earlobes, palms, or conjunctiva. And it's very important to check for occult blood in the stool with the patient with iron deficiency anemia, as there can be an issue with bleeding that's causing this. Microcytic hypochromic anemia. Let's look at sideroblastic anemia. Heterogeneous group of disorders characterized by anemia of varying severity caused by a defect in mitochondrial heme synthesis. This is characterized by the presence of ringed sideroblasts within the bone marrow. Now, ringed sideroblasts are erythroblasts that contain iron-laden mitochondria arranged in perinuclear collar around 1/3 or more of the nucleus. There's increased levels of iron in tissues. Hypochromic erythrocytes, either microcytic or macrocytic, depending on the form of disease. There's multiple etiologies, share the commonality of altered heme synthesis in erythroid cells in bone marrow. Sideroblastic anemia might be acquired or hereditary. Acquired is most common and is idiopathic or is associated with other myeloproliferative or myeloplastic disorders. Reversible SA is associated with alcoholism. Hereditary, this rarely occurs mostly in males, suggesting a predominant X-linked transmission or missense mutations. And here on this chart, we have the hereditary and different acquired forms of sideroblastic anemia or causes of sideroblastic anemia. Clinical manifestations, hemoglobin level may be down to 4 to 10. Cardiovascular and respiratory manifestations may be present. Signs of iron overload, such as hemochromatosis, splenomegaly or hepatomegaly, might be a bronze tint to the skin. There could be neurologic and epithelial alterations commonly associated with other anemias are absent. So you're not going to have those same neurologic and epithelial alterations as you see with other anemias. Complications, hemosiderosis of cardiac tissue results in heart rhythm disturbances and CHF. Diagnosis, bone marrow exam. It's going to show marrow packed with erythrocyte stem cells, mononuclear phagocytes loaded with iron in the form of hemosiderin. Normocytic normochromic anemia. Erythrocytes are relatively normal in size and hemoglobin content, but insufficient in number. 5 different distinct groups: aplastic, which is damage to bone marrow; post-hemorrhagic; acquired hemolytic, such as immune destruction of erythrocytes; or hereditary hemolytic, such as sickle cell; or anemia of chronic inflammation. Normocytic normochromic anemia, I'm just going to cover aplastic anemia. This is a critical condition characterized by pancytopenia, or the reduction or absence of all 3 blood cell types. This is resulting from failure or suppression of bone marrow to produce adequate amounts of blood cells. The incidence is rare, with about 2 to 5 new cases per million per year. Idiopathic aplastic anemia is the most common type and accounts for about 75% of the cases and is considered an autoimmune disease. Secondary AA, about 15% of the cases caused by chemicals and ionizing radiation. Characteristic lesion of AA is hypocellular bone marrow that has been replaced with fat. Aplastic anemia result from autoimmune disease against hematopoiesis by cytotoxic T cells. There is a genetic predisposition to this type of anemia. Clinical manifestations are insidious and related to the rapidity with which the bone marrow is destroyed or replaced. About 50% of cases progress rapidly, with a high risk of death from overwhelming infection or bleeding. Diagnosis is done through blood tests and bone marrow biopsy, and management is bone marrow transplant, immunosuppression, and identification of high-risk individuals. Okay, alterations of leukocytes, lymphoid, and hemostatic function. Let's first look at alterations in leukocyte function. Leukocyte function is affected if too many or too few white cells are present in the blood, or if the cells that are present are structurally or functionally defective. Quantitative leukocyte disorders, infection, and leukemias. These result from decreased production in bone marrow or accelerated destruction of cells in circulation. Qualitative leukocyte disorders are disruptions of leukocyte function. Phagocytic cells may lose their phagocytic capacity to function. Lymphocytes may lose capacity to respond to antigens. Okay, let's look at leukemias. Clonal malignant disorder of leukocytes in the blood and blood-forming organs. Common feature of all forms of leukemia is uncontrolled proliferation of malignant leukocytes, causing overcrowding of bone marrow and decreased production and function of normal hematopoietic cells. Classified based on predominant cell of origin, such as myeloid or lymphoid, and rate of progression. Acute leukemia, there's undifferentiated or immature cells, usually a blast cell. Onset is abrupt and rapid with a short survival time. Examples there, we have acute lymphocytic leukemia or ALL and acute myelogenous or AML. ALL, there's a presence of 30% lymphoblasts in the bone marrow or blood. Chronic leukemia, the predominant cell is more differentiated but does not function normally with a relatively slow progression. Chronic lymphocytic leukemia or chronic myelogenous or CML. Now, leukemia is more common in adults than children. ALL is the least common type overall, but it is the most common type that occurs in children. CLL and AML are the most common types in adults. Most common genetic abnormality is reciprocal translocation between chromosomes 9 and 22 and Philadelphia chromosome. And here we just have different symptoms and what the blood may look like, and different ways of treating these leukemias. Alterations of lymphoid function, malignant lymphomas. Lymphomas consist of a diverse group of neoplasms that develop from proliferation of malignant lymphocytes in the lymphoid system. We have Hodgkin's lymphoma, which is characterized by its progression from one group of lymph nodes to another, the development of systemic symptoms, and the presence of Reed-Sternberg cells. Reed-Sternberg cells represent the malignant transformed lymphocyte. The triggering mechanism for malignant transformation is unknown. It's often found, a patient may be asymptomatic and the mediastinal mass may be found on routine X-ray. Cervical, axillary, inguinal, and retroperitoneal lymph nodes are the ones most commonly affected. Hodgkin disease-related lymphadenopathy, pressure and obstruction as local signs and symptoms. So those lesions may be pressing and obstructing that are causing symptoms to occur. Non-Hodgkin lymphoma or B-cell neoplasms include a variety of lymphomas, including myelomas, that originate from B cells at various stages of differentiation. There's a progressive expansion of B cells, T cells, and natural killer cells. There can be localized or generalized lymphadenopathy, and lymphomas are classified as low, intermediate, or high grade. Disorders of platelets and coagulation, purpura, which is diffuse hemorrhage into the skin tissue that results, that is visible through the skin. Thrombocytopenia is a platelet count less than 150,000 platelets per microliter of blood. This results from decreased platelet production, increased consumption, or both. This might be congenital or acquired and primary or secondary to other acquired or congenital conditions. Heparin-induced thrombocytopenia. This can occur in patients treated with heparin. It's immune-mediated and is considered an adverse drug reaction caused by IgG antibodies against heparin platelet factor 4 complex, leading to platelet activation through platelet receptors. Immune thrombocytopenia purpura, or ITP. This was previously known as idiopathic, but it's now recognized as an immune response. This might be acute or chronic. Acute form is most frequently in children, and it's usually secondary to an infection. Chronic is associated with autoantibodies against platelet-specific antigens. And autoantibodies, usually IgG, but IgA and IgM have also been identified. Thrombocytic thrombocytopenic purpura, characterized by thrombotic microangiopathy in which the platelets aggregate and cause occlusion of arterioles and capillaries within the microcirculation. And here we just have a picture showing this diffuse purpura. Thromboembolic disease, thrombus, a stationary clot attached to the vessel wall. We have arterial thrombi, which form under conditions of high blood flow and are composed mostly of platelet aggregates held together by fibrin strands. Venous thrombi form in conditions of low flow and are composed mostly of red cells with larger amounts of fibrin and few platelets. An embolus is a thrombus that detaches and circulates in the bloodstream, and this can block blood flow, leading to ischemia. Often these end up in the lungs, which can be fatal. Virchow triad, this is injury to blood vessel endothelium, abnormalities of blood flow, and hypercoagulability of blood, and these lead to an increased risk for thrombus formation. There are hereditary thrombophilias, inherited disorders, primary factor 5 lead-in, dysfibrinogenemia, hyperchromocystinemia, and platelet defects. Inherited and acquired disorders, antithrombin deficiency, heparin cofactor deficiency, protein C or S deficiency, and plasminogen deficiency. Now, acquired or secondary could be antiphospholipid antibodies, myeloproliferative syndromes, and Trousseau syndrome. And that's all I have to cover on hematology. Please let me know if you have any questions. Please keep in mind that this presentation only covers a small portion of the chapters, and it's student responsibility to ensure that you are reviewing the chapters in their entirety in order to complete assignments and to prepare for the exams in this class. Thank you all and have a great day.